I'm Dr. Michael Doyle. I'm the medical piece of the panel today. I'm the medical director at Connecticut Fertility. I recognize many of you from the Men Having Babies group and from my office here in the city, and many of the top professionals in the community are here today. It's, I'd say personally, very rewarding to see a room full of families in the making and families to be, especially at this hour on a Sunday morning. 20 years ago, when I started Connecticut Fertility and started practicing reproductive medicine, not only were the medical treatments in general relatively limited and relatively not so effective, very few gay men and even lesbians or other members of the LGBT community at that time had open access, and I'm sure we will all agree that a day like today would probably have been very hard to imagine. So today, I'm going to talk about the medical piece. What I often see is that the medical process can, on the surface, seem overwhelming, like any process that has multiple moving parts, if you will. You have the parents and their medical and personal needs and issues. Obviously, there's usually an egg donor and everything that goes along with that, and the surrogate, and the synchronization and the orchestration of those moving parts can sometimes seem confusing, and that's usually where people start with the most amount of concern, and that's what I'm going to focus on today. What I express is the strategy of breaking these processes down into very doable, small steps, kind of like a marathon, if you will, 1 mile at a time. And breaking down the process so that each step involves decisions and choices and control, which is the good news. There's a lot of that now that there didn't used to be, but with it requires an important and thorough understanding of the medical pieces. The really good news for today, and what I hope you most take home today from me, is that the medical part of this is highly doable, highly successful. The technology really has gotten to the point that with the top agencies and clinics, about 98% of people who embark upon the journey will walk away with at least 1 baby if they try for up to 3 embryo transfers. And that, as a physician, is extremely gratifying, because the days are gone where the technology was limited and these were miracle babies. In a sense, all of our children are miracles, but the technology and the statistics are such that even with a single embryo transfer, pregnancy rates are in your odds, and the likelihood of walking away from this is so high with the baby that you and we with you can focus on the process as well as just the pieces of the technology, and that you can become very, very engaged in the choices and the controls and the options that we're increasingly able to offer you because of the technology. Including the relationships, which I'll talk the least about today, but I do want to echo what you've already started to hear, and I know it's going to be the theme of the day, which is that as parents or parents-to-be, you're not just walking away with a baby and starting your own family, but you're really merging the family and friends in your world with the family and friends of the surrogate forever, and changing those relationships in ways that I think sometimes at the beginning of the process may or may not be obvious, and they are every bit as empowering as the baby or the babies that you will raise as your own. And that's really exciting, and I know that's a theme of today, and I wanted to echo it. But let me go back to the medical piece, because as I said, the great news is it works, but there's choice. And that's great, but along with choice comes informed consent and lots of decisions, and those decisions can at times be stressful. So I'm going to talk about 3 areas: donors and how we screen them, and what you might look for in terms of the donor you choose and the donor matching options that you might consider; the in vitro fertilization process, the IVF, which really just stands for the in vitro or in the laboratory fertilization of the eggs and the creation of the embryos, because ultimately where IVF has landed us, and the reason it's so successful, is we're better and better at producing higher quality and greater impact embryos than ever before, so that we can focus our medical technology on minimizing the number of embryos that you need to place into your surrogate without compromising the likelihood of success. And there's some power in that, because by putting in one or seldom ever more than 2 embryos. The majority of people are pregnant each time, and the risks of multiple pregnancy. Twins we'll talk about, but certainly a higher order multiple pregnancy can be altogether eliminated. Because we're taking really highly fertile women, both egg donors and surrogates, almost always with relatively fertile men, and putting the pieces together in such a way that the last thing we want to do is take such a high yield, high impactful situation and create a high risk pregnancy. And multiple pregnancy is probably the biggest concern on the medical side of the equation that whatever physician you work with is going to have. So donors, who donates their eggs? Lots of women apply to be egg donors. I think everybody here, I know everybody here on the panel and even in the room have high standards for the donors, and the screening that we undertake is extensive. It's psychosocial, it's certainly health. The FDA has very specific requirements for infectious disease that all intended parents, the egg donors and the intended parents, need to pass, so that we're not creating embryos that would place a carrier at risk for any type of infection or infectious complication. Drug, nicotine testing. I can't emphasize how important genetic testing, in at least my opinion, is for the donors. And so besides all of the important personal and dynamic aspects of choosing a donor, choosing donors who have extremely well-screened genetics, which clinics provide, family histories that are very evaluatable and transparent to you, critically important, because you're creating the child that you're creating will obviously have the genetic component of the donor, and those things are highly, highly measurable and quantifiable. Lastly, I think, as John already echoed, donors can be assessed based on previous donations. And certain donors are ideal for certain men or couples who maybe are looking for a more prolific donor who produces lots of eggs and who is highly likely to be able to produce twins or multiple separate pregnancies or siblings over time. And people who have their short and long-term goals that include a relatively larger family are often steered toward donors whose single egg donation for you one time will likely be able to achieve all of your short-term and long-term family building goals. Whereas if you're a single guy or a dad or a single man in a couple who only wants one baby one time, lots of options for sharing eggs or taking donors who don't produce as many eggs but are perfect in every other way and not compromise your goals. Donors can also be evaluated before they take any fertility drugs with blood tests that are called FSH levels and ultrasounds of their ovaries, so that we're really actually pretty predictive and accurate in our assessment of this woman based on her age and all her testing is likely to produce this type of egg, this many eggs and this many embryo quality. So not taking donors without an extensive amount of medical or genetic screening, I think is very, very empowering. What happens is they take the fertility drugs, we retrieve the eggs in a procedure that takes about 10 or 15 minutes. A typical egg donation will give around 18 to 20 eggs. Typically 80 to 90% of the eggs will fertilize. They start growing into embryos, and we evaluate embryos throughout their 5-day existence in the laboratory before we transfer them back into the carrier. And we can evaluate embryos visually. So again, 20 eggs, 18 or 16 fertilized, 12 really good embryos 2 or 3 days later, maybe 8 embryos that are called blastocysts a few days after that. By letting the process unfold under the microscope, and even by testing the DNA of the embryos, which in some cases we do through embryo biopsy, we're able to zero in on the cream of the crop, the top, the number one embryo, so that we can be extremely selective and impactful without having to put in multiple embryos and expose you to the risk of multiple pregnancy. The sperm washing process that always is a part of the IVF maximizes the likelihood of fertilization, makes it very safe for us to treat HIV positive men, which more and more clinics are also doing. Finally, just in closing, the carrier piece, just as important that the carrier screened as medically extensively as the donor, but the surrogacy agencies are much more in the driver's seat when it comes to identifying and screening the carriers, because in addition to the medical issues, which all the clinics are involved with, the legal aspects and the psychosocial aspects and the many things that their social workers and people who visit their homes and provide the support systems are more suitable coming from a surrogacy agency than from a medical clinic. So people starting out will often start with an agency and then move to a clinic, or they may often start with a clinic and move to an agency, and they will always pick their surrogate from an agency, and you have many options from which to choose your egg donor. Ultimately, it all coalesces into what we all here aim and I think achieve, which is a highly synchronized, orchestrated process, which you as the parents are firmly in the driver's seat of. So, good luck to all of you. I know some of you are in the process, some of you are starting, and again, like I said, embrace it, enjoy the process as much as you can, and really have very little reason to doubt that from a medical technology side that things are really in place for you to be successful and to achieve the family that you want. Thanks.